All right, we're all set to get started. Welcome, everyone. It is a privilege to spend some time with you on this Thursday at our community meeting. This is an unprecedented time for all of us, and makes it all the more important to have these times when we can get together and share with one another what's going on in our lives professionally, and I would say personally as well, because this really crosses all boundaries for us as a community and as a nation. So our goal today is twofold. One is to level set where we are as a healthcare providing community, to hear from each other what are the developments, what are the key questions, and hopefully also what are some of the solutions that are out there, or solutions that remain to be seen. And the other one is the actual original idea behind this community meeting weeks ago was actually because we'd had a bunch of discussion on the listserv early in the year on billing, was actually to just get us level set on sort of billing strategies and all of that. So some of that has been co-opted by a lot of the telehealth conversation and the billing related to that. So if that is an area that we want to focus on today that folks are interested in talking about, we're open to talking about that as well. But obviously the bulk of the meeting will be COVID and all things COVID related with regard to our work. Now, let me tell you a little bit about the structure of our meeting today. What I'm going to start off with here is just a little bit of a centering meditation. I've been starting almost all my meetings with some sort of meditation these days because there's so much distraction out there that just getting centered for a meeting like this can be difficult. And I think it's important for us to be clear-headed and clear-minded, centered for each piece of work that we encounter each day. So we'll start off with a very, very brief meditation time. And then I'm going to level set us a little bit. We're just going to talk about what I've been hearing across the nation. And so we'll just do a very brief sort of level setting experience on a slide deck. Following that, we're going to hear some reports from some folks across the country who've been kind enough to share what they are experiencing in their localities, just to give us, again, a flavor for how this is affecting folks in different regions of the country. And then we're going to open it up to the community to ask, for you to ask and share what your experiences have been. The end result, I hope, is that we as a community come together and feel supported by one another, as we have through the listserv and other means. And then secondarily, also to give us at CFHA some direction around how we might best support you and how we might support all of our clinics that are continuing to try to provide care as best as they can. So without further ado, I'd like to invite you to just take a moment. And if you wish, wherever you are, if you're able to get yourself in a comfortable position and join me in this brief breathing meditation. Now, you all know how to do this. Most of you should anyway. But we're going to do deep breathing, and I'm going to let you breathe at your own pace. But I want you to center in on each breath that you take. And as is our custom, when we focus on our breathing, we begin to take that brief pause that's essential at the top of our breath and at the bottom of our breath. So I invite you to just take a moment to allow yourself to focus just on your breathing. To breathe in slowly, surely, and then to pause, holding the breath at the top ever so briefly, and then allowing the breath to escape slowly and surely. And at the bottom, to take another pause. And to repeat this pattern, focusing in on your breath, giving yourself permission to simply focus on this one basic, very human activity, to allow yourself to take time away from the many thoughts you might have circling in your mind and in your heart. Those are important, but there is a place and time to attend to those. So as they come, gently attend to them and allow them to escape your awareness. And return your attention, return your focus to each small, deep, sure, and steady breath. As you allow yourself this moment, remind yourself that it is okay. And in fact, it is essential that you allow yourself more of these moments, that you give yourself permission to be human, and that your breath is a reminder of your deep, enduring, and resilient humanity. I'd like to ask you then to take one more strong, resilient breath. And then to slowly open your eyes if you have them closed and bring yourself back to your present awareness. Okay. Well, I hope that you've been doing a whole lot of that lately. I certainly have. Let's keep that as our center point throughout this meeting and hopefully throughout the rest of your day. Let's gently switch here to talking a little bit about what has been going on. I'm going to share my screen and help us to level set here. So I tried to summarize what I have heard from you all and also from other sources about the main questions and areas that we've been struggling with and working with in the last week and a half as this COVID stuff has escalated. So one of the areas was what systems were trying to accomplish. And I really want to recommend to all of you who are especially in leadership positions to really align what you're doing. A key tenet of integrated care is that we align what we're doing with the systems of care are trying to do. And that alignment is what really makes us good teammates. So our systems seem to have been trying to screen and divert COVID suspicious patients. That's a fairly obvious one. And then changing the level of care or the quantity of care to provide limited, acute, necessary care, and on some level delaying all other care. And this is an area that I'm particularly concerned about. And I'd like to hear from you all today about what the level of delay of all of the care is, because we may then be dealing with a backlog of issues, particularly in primary care. Once this clears up, I'm concerned that we actually may be in a world of hurt there on that end as we delay care. But there are some systems that have been quick to turn medical and behavioral health telehealth on to avoid delaying as much care as possible, and others that are frankly behind and are just basically delaying all unnecessary care. Obviously, there's efforts in clinics to avoid minimizing the spread of COVID, which has resulted in varying policies around who comes into work and who doesn't come in and in what quantities people come into work. and of course, all the internal protocols around COVID-related issues. We've also heard concern about keeping the lights on, clinics that are concerned about reimbursement as they switch over to telehealth. Fortunately, there's been some indication that there's been some flexibility with regard to telehealth billing, at least in some localities, but certainly not all. And there's still lots of outstanding questions related to what payers will reimburse for what forms of telehealth. And then, of course, lots of systems, as you've seen, trying to engage telehealth very, very, very quickly. Some systems have moved faster than others. The other key piece that I've seen us talk about has been, how does behavioral health fit in? And what I've noticed is that high integration clinics, in other words, clinics that already had high levels of integration. And when I talk about integration, I don't just mean clinically, but also administratively. So looking at the sorts of levels of integration, when you think about the HRSA 6 levels, or if you look at the MEHAF and the way it describes integration, folks with high integration seem to have been able to engage plans right away that included behavioral health, included transitions to new workflows, telehealth, and on-site responsibilities. Whereas low integrated clinicians, and I'm borrowing this word from Jennifer Hodgson because I think it's a great word to describe, almost ghosted behavioral health staff, especially in the initial phases as they kind of dealt with the crisis and kind of forgot the behavioral health staff kind of existed and needed strong direction and good messaging. And so some of those clinics really did not provide a very clear vision for what role behavioral health would have. The other thing that I noticed related to that was that the high integration clinics really kind of knew already that they had good resources in their behavioral health staff to support other staff, to be doing resiliency work, mindfulness work, et cetera, in clinics. And that has not happened universally across these clinics. And there have been variable responses thus far related to whether behavioral health remains in clinic or not. Most clinics at present, at least from my view of things, appear to have all staff working remotely or majority of staff doing their work remotely. Some clinics have hybrid models where they have some staff remain in clinic. They may even be in clinic but not having patient contact in clinic, but just be available for crises or things like that. And of course, questions still remain, especially about clinical workflows that involve integration. So one of the interesting byproducts of moving to telehealth is that essentially you can move from being a very integrated setting to being more co-located, essentially, to being a referral-based model because of the complexities of doing warm handoffs in a telehealth type space. So questions really remain around that. And then from a patient standpoint, the main response for patient care has been the rollout of telehealth services or increased use of existing phone services and phone triage. That's been the main response that I've seen. And the focus has been on the public health response, but I am concerned that that pretty soon we ought to be changing our focus from just getting out the word that people should be isolating and all that to really talking about what patients can do to meet their primary care needs and other needs, whether you're working in a specialty clinic or hospital-based service. I'm concerned about developing this big backlog of demand once sort of primary care opens its doors. And I'm also concerned about patient safety during this time, both medical safety as folks who have chronic issues maybe struggle with getting access to care or feel like they don't have permission to get access to care, which is a horrible message for us to send. And also on the behavioral health side, the enduring effects of social isolation and its impact on those with mental health needs and those even without mental health needs who will be affected by all this. So those are outstanding questions. And then we've talked a lot about staff needs. There's been an intense amount of resource sharing, which has made me incredibly grateful for this community. You guys are awesome. Yeah, it's just been inspirational to see it happen. So it's been great. Some clinics have, as I said before, instituted some practices to help with debriefing, with mindfulness, etc. I'd love to hear from you all today about whether those have gone well, whether your clinics are doing that or not. And then, of course, physical safety has been a key issue as we think about the limitations, the limited supply of PPEs, etc. So those are proximal concerns that we're still struggling with. And then there's this whole category of unmet needs that I've been thinking about. I am someone who knows very well the adjustment from working in clinic to working from home, because that's been my life for the last 4 years. But a lot of folks don't know how to make that transition, and it is a transition, particularly if you're doing clinical work from home. And I think that's an unmet need right now to help folks transition to working from home and develop those strategies for that. And then also figuring out strategies to keep these teams connected, whether it's a behavioral health team or whether it's a behavioral health team with the medical teams. It's really, really challenging to do. I can tell you that I do half-day clinic a week at UNC Family Medicine. I just have had no contact whatsoever with my physician colleagues, and it's disconcerting. I'll end with some early silver linings here. We've heard some flexibility demonstrated by peers and regulators, unprecedented, really. Just today, in fact, just right before this session, I learned from an email from the National Council that the legislation that passed in Congress, or at least passed the Senate, going to the House, I believe, did include further flexibility related to 42 CFR Part 2, related to consent for releasing information for folks struggling with SUVs. So, again, unprecedented, and I hope that some of this flexibility actually persists, because we really need this stuff beyond these sorts of crises. Obviously, community responses have helped. The telehealth experiment has been, and I think will be, one of the things that endures. I think there will be some shift towards looking at telehealth as just one of the ways to engage our patients more effectively. And this is exposing patients to what those of us who've been doing telehealth for a long time know already, that it's a very effective way of meeting needs for many patients, not all patients, but many patients. And I think there's also an opportunity during this time for those of you working in behavioral health integration to really champion how important behavioral health integration is. There's so many ways in which integration, I think, helps in these sorts of crisis situations. And this is an opportunity to highlight these factors. So that's a little bit of a level set. Now I'd like to turn our attention now to regional reports, and I'm going to start off with Mary Jean. Mary Jean Mork is up in the northeast corner of our country. Mary Jean, could you tell us, just give us a couple of minutes on what you're seeing in your state and your region?
Hi, thanks. And we're early on in this struggle, I think. So I'm very interested to hear from others. We have Neftali knows, we're within a large health system that is made up of various hospitals. So we work within 8 different hospital systems, and we have had 8 different responses to what's going on here. So that when you talk about the levels, we've had some terrific embracement, and then we've had others who forgot about us. What we tried to do for our staff so that they didn't take it personally, feel bad, we went to a family therapy frame, and we really thought of ourselves as the sibling who did not have the special needs right now. So we have two siblings with special needs. We have the medical side, and then we have the specialty behavioral health side, both of whom have pretty high needs right now. So we're the one who doesn't have as many needs, and we need to keep being resilient, keep taking care of each other. It has allowed for some real creativity and innovation from our staff, and that resiliency is really coming through. I know it can't be sustained, but we're going to work really hard at trying to do what we can with it. The other thing that you talked about is the technology. We are working really hard to maximize technology for our system. That's been interesting as well. Do we use a license? Do we use an unlicensed? I know we were originally going to talk about billing and coding, but that's been fascinating too. What should we bill? When we talk about telehealth, there are really two parts. There's the phone and the televideo, both very different. So all of those things every single day are questions, and we have many more questions than we have answers. But I would say our system, it's really our third week into it, which for I'm sure some people will feel, boy, like ancient history. But at the third week, more of a light is being shown on behavioral health and our program and what our program can do to support the larger system and the staff within the larger system. But we're very much in the early stages of this. I will be very interested in hearing from others. Thanks.
Thanks, Mary Jean. Really appreciate it. Now let's go to travel a little bit south to the city of New York. Andrew, I'm going to unmute you. Andrew Phillip, can you tell us a little bit about what's going on in your area, what you're hearing from the clinics that you work with?
Hey, sure, Neftali, can you hear me?
Yep.
Okay, great. Yeah, so New York is, gosh, we've been, I think we're a little bit more in the spotlight than usual lately with our governor, and obviously being kind of at, one of the major epicenters for COVID as it stands right now. At Primary Care Development Corporation, where I'm working, we're here in New York City, but we work with organizations all across the state, and that includes, New York, we're kind of unique in that we have major metro areas, but also frontier areas. And so it's been pretty mixed, really. Fortunately, we've had good support from our, we have 3 state agencies here that really govern health. Our addiction services to mental health, and then our primary health services, and they're all pulling together more than they usually do, frankly. There's been a push towards getting payers to reimburse for telehealth. Fortunately, our state agencies have put out guidance relaxing regulations around telehealth independently as well, and making sure that there's parity with Medicaid. So I think we have, as far as, nationally goes, I think we have a decent infrastructure to support what's going on. But what we're seeing with a lot of our stakeholders is that some of the larger systems, Neftali, like you mentioned, where there's higher, deeper levels of integration under a single entity, they're doing okay. We have a lot of people working from home, and that's been possible. But a lot of our population, especially the safety net here, is supported by small practices, so small primary care practices or even solo practices. And then we also have a lot of standalone behavioral health organizations that have been kind of working towards that mid-level of integration and co-location. And so this is not helping those folks, unfortunately. We've actually been seeing small practices shuttering their doors for right now if they don't have the infrastructure kind of from the get-go for telehealth. The state's also been in a budget deficit, and particularly worsened when we didn't receive our federal delivery redesign funding this year. And so this came just after that. And so it's been a tough spot with our budget. And so we're really advocating to preserve and increase the primary care and behavioral health spends, but also challenged because, as people may know, even members of our state government actively have COVID. The person who oversees our budget committee has it right now. Our capital has been in lockdown. So although we're expecting some of the budget to go through today that supports primary care and behavioral health infrastructure, or this week at least, it's it's been delayed by weeks, and we've already been at that spot. And so those smaller organizations, the behavioral health organizations especially, have really been struggling. And so we're working with them now to really, first of all, everyone's just trying to figure out telehealth, but also we're trying to view this as an opportunity for kind of advancing those people in that mid-level of integration who are looking to partner with primary care services, and maybe now there's an opportunity to do it since telehealth is getting somewhat easier to provide. We're also hearing reports that primary care providers are really, I'm sure like everyone in the country, are being asked to do a whole lot more than they were before. And so I think that's adding to the pressure for integration. And there's some unique things that have been set up here. We have the state set up a hotline that people can call to get mental health services. We've had over 6,000 mental health providers in the state who have volunteered to help in this effort. But just like everyone else, our healthcare providers, whether they're fully integrated or not, are having trouble accessing PPE and all that kind of stuff. So we're really big, but we're basically having the same kinds of problems everyone else is having, and it's been exacerbated by our budget deficit that we're in right now. And I'll also add one more thing. I'll just add in here. We're PCDC. We provide capital investment, and so we're working with a few other lending coalitions to try to inject kind of carryover capital into some of the primary care and behavioral health practices across the state. There's also a number of foundations that are issuing emergency funding too, and we're of course partnered with SAMHSA and the National Council for Behavioral Health. As you mentioned, we have a bulk of the CCBHCs here in the state, and so fortunately it does seem like they're getting more support, but everything's kind of unfolding as we see it here.
Neftali, you're muted.
Sorry, the host should know when they're muted. I don't know why. So sorry, I was talking over Andrew. Andrew, thank you for that report. I really appreciate it. And I was saying that financial piece is going to be more and more important going forward as practices really do struggle. Let's move south now to my home state here of North Carolina. Jennifer Hodgson out of ECU.
Well, Neftali, really appreciate your summary at the beginning of this because I thought it really spoke to a lot of the things that we're experiencing. So I'm located in Greenville, North Carolina, and we are, for all intents and purposes, a very rural community. So we're on more the eastern side of North Carolina where resources are already pretty thin. I have the privilege of supervising students and alumni and having contacts all throughout the state and across the country. So a lot of the things that I'm seeing and hearing about are summative. And, I have seen, so we're pretty new at this as well. We have currently 8 cases in Pitt County, which is the county I reside in. So our mayor yesterday just issued a stay in place order in Greenville, and there's a lot of restrictions on when you can leave your home as far as where you can go to, and for essential travel only. And so they've been able to keep, essential businesses open, grocery stores and other, but we're, really struggling with how to meet the needs of an already underserved, uninsured, low-resourced community with this. And so we have areas where they just don't have internet access, or the broadband can't accommodate telehealth. So we're doing our best to adjust and use the phone, but you can only do so much with the phone. And so I've been supervising people to try to help them to structure sessions when so much of what we do in behavioral health is nonverbal and visual, and kind of reacclimating that role. Also addressing the humanness in our behavioral health providers, that they too are wrestling with anxiety and their own health issues, and trying to help, to validate that and to make sure that they feel they're safe and they're supported and cared for by their work systems, so that we can help them to help support the work systems. And so I think if I've learned a lot about being a leader through this, and I've certainly have had to learn it other times in my professional career as well, is just learning how to slow down and listen and validate people's experiences, whether it's the healthcare providers, whether it's, your behavioral health providers, the staff, the people who are now asked to stand outside the front door and screen people, the people who are having to interface with the community who don't get PPE because they're not deemed essential. That has also had me thinking a lot about PPE and who are essential providers and who should have access to the equipment, not just behavioral health, but in general. If we're going to conserve the equipment, what message does that send to other people who are on those teams? And so it's really got me thinking broadly about the way that we define teams and roles. I would honestly say that it's not even our low integration clinics that have struggled. Even some of our high integration clinics have struggled as well. And it's all about how leaders are trained to handle crises. And I think that the leadership style and the way that information is shared and disseminated, a lot of that impacts the anxiety in the system. So if you think about it, your home environment, and I have 3 children. And so I've really tried to keep, the TVs off, the flow of information to be very age appropriate. And I've just been very conscious of how I come in and out of my home. My husband's a pharmacist, same thing. And I think, but when they ask questions, we answer. And when they're anxious, we address it. And so I think just some of those policies and protocols with supervisees and employees and staff are really important, that they feel like they're getting information and not being ghosted on what's happening, even though we know that parents and higher leaders are holding so much on their shoulders, or having to make decisions they've never had to make before. And I think that that's some of the things that I've been really learning about this. And I know, like Neftali said, out of chaos comes opportunity. We're going to find new ways to deliver services that are even better than before. Being able to showcase how we function as teams, behavioral health providers really stepping up and even doing more to help carry some of that than they've been in previous contexts. And so I'm really looking forward to finding creative, innovative ways. I'm also very conscious of the need to care for providers and to make sure that they're recognized for the work that they're doing, and how are they transitioning to their home, and how are they taking care of themselves. And so I think as BHPs, even though we don't get reimbursed for that, that's a huge part of the service that we're needing to provide right now, and holding that same place for leadership in the systems. It's so easy when you're in a leadership role, you feel this enormous weight. And I know some of you know this, when somebody turns to you and says, "Thank you so much. We know you're working hard on our behalf." I mean, it just hits you that, okay, I'm not trying to make things difficult. I'm not trying to withhold information. Thank you so much for recognizing that I'm just trying to, disseminate things as best as I can. And so I'm seeing leaders really finding their strength in doing that. And that's helping systems to settle into some sort of normalcy in a very abnormal time. In North Carolina, they're really doing great work at our Department of Health and Human Service levels, trying to open up codes for telehealth, for the telephone work that we're needing to do. Some of our virtual platforms are problematic. I don't know if any of you are having trouble, but one very common one is WebEx. And while it's encrypted and secured, it has been very problematic for running any kind of appointments, the sound, the connections, the broadband. And so we've been given privileges to use other platforms that have worked a little bit better. So I'm hoping that feedback is getting to the WebEx teams and developers so that they can sort of figure out where some of these problems are. I don't know who's communicating that to them. So I think just seeing some really good work in those areas. Oh, and we have a 3D lab on campus. I emailed them the other day after learning how a 3D lab in another setting was printing face shields, and they're already on it. They're already starting to work and collaborate on some designs of masks and face shields that they can print out of their design lab. And so I think really capitalizing on those unique things in our communities and being able to help people to find relevance and pull in all these resources has been really helpful. So we've learned, who is essential, who should get the PPE, how do we want to utilize behavioral health in things like, situations like pandemics? We want to be seen as a part of the healthcare team, but we can't just say, okay, we're out when it gets scary and risky. And so how do we stay appropriately engaged and safe and essential? And I think that's been where I've asked Neftali to help us to come up with some agreement somehow where we can say, here are some of the common services that we can provide during this really difficult time. So, but we have heroes all around us, and I'm just really glad that CFHA is doing this and taking this time to address, something that we've never had to address before.
Thanks so much, Jennifer. We have just a couple of more report outs here, but while folks are reporting out, I want to invite everyone to submit any questions you have that you would like the group to address, and they can really cross the gamut of personal to professional. Again, I think this is a cross-cutting thing, so we want to be mindful of all of the needs that we bring to bear. So put those in the chat portion, and if there's, we'll select those to start off our conversation after the brief reports. We're going to cross the country now to Laura Heesacker, all the way over at the northwest corner of the country for a brief report. Laura?
Okay, can people hear
Laura,
me?
Yes, there you go.
Okay, great. Yeah, thank you so much, Neftali. So I live in a very rural area of Southern Oregon, and I'm representing a Medicaid health plan, and we have that plan down here in Southern Oregon, as well as I'm also part of a larger group called Care Oregon, which insures the most Medicaid lives across Oregon. So I'm part of a network of behavioral health innovation specialists that are supporting integrated behavioral health clinicians within the different regions that our health plan serves. And we have a value-based payment strategy for integrated behavioral health. So that's just a little bit of context that I'll be speaking from. So our communities, especially in Southern Oregon, are just now moving to be fully telephone or video. And as of tomorrow, most of them are moving off-site to their homes. And although some of you maybe saw a post that I posted on the listserv, Joan Fleshman, who's the behavioral health director at OHSU, our largest health system with the most integrated behavioral health clinicians, as of, I believe, last Friday, made a decision to send all of her behavioral health clinicians home and working from home, all on telephone and video. So from a health plan perspective, some of the things that we are doing is engaging, since we hold non-emergent transportation, and so we are looking at creative ways to have them be doing things like delivering food boxes to patients so that they don't have to go out, potentially other things that we'll be coming up with. We are looking at providing blood pressure cuffs. This is coming directly from our integrated behavioral health clinicians, who I'm doing weekly huddles with to get a sense of how we can help each other during this time. And so they're giving us fantastic ideas, like providing our members and the community with blood pressure cuffs, A1C home machines, anything that we can be doing to help them be able to continue to care for themselves and get this information and feed it to their health systems without them having to go into the clinics. We recently had one of our telehealth MAT provider open up their services across the whole state Boulder Care. Maybe some of you know it, and I just texted to see if that was an offering out across the nation, but if it is, I'll send that out on the listserv. So lots of groups are coming forward to provide services and offer services. As a health plan, we're in the process of putting together lists of people at the request of our behavioral health clinicians in our primary care sites. They're asking for lists of patients that are maybe considered more in those high risk groups, so that they can be reaching out on the telephone and finding out, if they are, if they're needing anything and how they can be helping them understand how to access healthcare. Just kind of looking at, we've put out we have flex funds available to our members as well as organizations, such as shelters. Just reading some other notes that I think Wi-Fi hotspots. We're looking at, as a health plan, can we provide Wi-Fi hotspots so that our community can have better access to the video platforms for the telehealth and phones, of course, and then also looking at charging ways for people to charge their phone, whether that's charging stations or for some maybe of our homeless community. I think I'll pause there, but yeah.
Thank you so much. Really interesting perspective there. And it just shows the breadth of the different pieces that we're all having to think of at the same time. And I'll just sort of put a pin on that notion, because I think it's important for all of us to understand the breadth of the cognitive load that we're all carrying right now is immense. The range of problems we're trying to solve, strategies we're trying to develop, and the associated emotions that we're trying to contain related to that, and also from our teammates in clinic. And then, of course, you add to that the issues within our own family lives. So it is really an immense burden that we're all carrying. I just want to remind folks of that, to remind yourself, take things one step at a time. This community is doing a great job of chipping away at this issue, and we'll continue to chip away at it. Now, I'd like to switch from the report outs, and I'm sorry, Ann, I don't think we have time for one more report out, but if you want to read Ann's post in the chat, she has something relevant to folks on Long Island, New York, psychologists in private practice and clinical practice, and a really key point there that state and county regional associations are being really helpful right now. I think that's true here in North Carolina as well, with helping practices make the transition to telehealth and understand some of the local issues related to payment and regulation. So look at Ann's comment for that. There's a couple of other pretty typical comments in the chat that I'd like to highlight and address. And those relate to lots of folks are looking for telehealth workflows right now. And I know that it's one of the things that we'd like to aggregate here at CFHA. So keep an eye on the Integrated Care News site. We're going to put weekly updates, weekly reviews, summaries, sorry, of all the listserv conversations, all the resources that are posted, and organize those in ways that hopefully make it easy for you to access. And any specific resources we're putting on our consultation website, which is integratedcareconsultation.com. There's a resource page there. We will link to that from the summary page anyway on the news site. And that has a really easy way to navigate the different COVID-related stuff, including any telehealth workflows that might be adaptable. Of course, every site is really different with regard to what they do. The other thing, Peggy DeCarlis, so hi Peggy, had a really good point about needing resources to assist VHCs in making this transition to doing telehealth work. And so one of the things that we've been thinking of doing is I particularly happen to have a good background in telehealth work from lots of projects that I've worked on related to it. And one of those includes like a little presentation on how to do informed consent and some of the basics of just how to manage a telehealth interaction. And so I think there are some existing resources out there, certainly some of them that already have been put out on the listserv. But if it's helpful to folks, we're happy to put that out there for folks as well, because it is an adjustment. You have to, and I'll just do a quick spiel on that because I think it's important. The key steps to getting someone up and running, other than just the technical pieces of having adequate bandwidth, having the right equipment. I always emphasize that even in a video conference interaction, the audio is actually the most important thing. So if your audio is cutting out, that's not good. If you don't have a good microphone on your laptop, you need to use an external mic. So pay lots of attention to audio, which also means testing it out with your staff so that you can hear what the patient is going to be hearing. Video, of course, try not to be backlit. And then you want to train your staff on how to introduce themselves and how to do the informed consent procedures well. And most of it's pretty similar to what you would do in practice. But one of the things that happens, since you don't have registration checking people in, you do need to check ID. So just check to see that people are who they are. That's what your registration staff usually does for you. So simple things like that, and then having a good spiel that you can get through quickly that doesn't turn off the patient and is long-winded is really, really important. If you have those sort of basics in place, most of the other stuff you can figure out as you go. However, as Katie Snow pointed out, the other reality that we face is that a lot of patients don't have either the bandwidth or the tech to make this work well. Sometimes if they have the bandwidth, they have an aging laptop or equipment that's not very good, or just don't have the tech expertise to know how to download software, et cetera, depending on your platform. So reverting to phone is not a bad thing. So if you're finding in your system, particularly right now, that you're struggling with trying to get to virtual and putting a lot of energy there and the system's resisting you, please don't wait. Use the phone. The phone is a great, as Jennifer said earlier, if you know how to use the phone, you can have a phone consult that is just as potent as an in-person consult. And so it's just a matter of just being confident on the phone, being able to structure your visit, do your good introduction at the beginning of your phone call, reaffirm to the patient that this is a consult. A lot of times we think of phone as a check-in tool instead of a consult tool, and that kind of creates a different mindset for the patient. You really want to say, no, this is our visit. We're going to get some work done today. We're not just here sort of doing a brief check-in. And so revert to phone, and you're not going to really end up losing too much by going to the phone. Now, I would like to just dovetail here, and Mary Jean, if you could just do you have any particular tips related to the billing piece in particular? You talked about, and this is something I've learned pretty recently, the difference between telehealth and phone and billing. Do you have a couple of nuggets that people can take home to pay attention to? That's part of the question that I see here.
Yeah, so the nuggets is make sure that when people say telehealth, you know what they're talking about. Are they talking about phone or televideo? Because at this point in time, the rules appear to be different for both. Televideo, the rules seem clearer, that if you're delivering a service that would otherwise be a face-to-face service, that it's generally going to be reimbursable. They've relaxed some of the rules about where you can do that. They used to have, Medicare in particular had rules about certain places that you could do it from and to, and those appear to be relaxed at this point in time. So the televideo appears to be the easiest to bill. There are probably some identifiers that would say it's a televideo. For phone, we do not have answers from our system because we thought we could just do a regular phone session. And I love that you wanted to make sure that a check-in is different than a session or a consult. So we thought we could just do our regular sessions over the phone and have those codes billed. There are some very confusing pieces. So there is a phone visit code that providers can use. It's a 994 something code. And we don't think that that is a code that should be used for psychologists or LCSWs. There's another code, a 98966 to 98968, which is also a visit check-in code for non-providers. And our system thinks that might be the code that we're supposed to use for phone visits. I'm not sure about that, but that's where we're at. The other really fascinating piece is that I have read what our Medicaid program has done, what Optum has said, what Cigna has said, and so is our director. And we thought, well, that means they're going to pay for phone visits. Our auditors and coders read the exact same information and they said, no, I don't think so. So I would not assume anything at this point in time. And it'll be great if people can get more clarity on that and then share that with CFHA. Thanks.
Yeah, and the other nuance, thank you so much, Mary Jean, for framing that. The other nuance that's important that I didn't realize up until now was just the initiation of those visits. In our system at UNC, for example, even though we have the flexibility from federal and state officials to use alternative platforms, they're not allowing us to use alternative platforms like Zoom, for example, because their compliance is saying that the visit must be initiated within EPIC, our EHR, in order to establish an audit trail. And so it has severely limited our ability to get started because they're just rolling out in a piecemeal fashion access to video visits across all the UNC providers. So, and that's just for the televideo work, not for the phone work. So the phone is a whole separate process where a patient needs to be checked in and checked out within EPIC in order to establish that audit trail. So those are nuances there where from a compliance standpoint, you're going to find varying degrees of flexibility and interpretation of requirements. I sense that the larger the institution, the more rigid they are with these situations.
Neftali, this is Laura. Can you hear me?
Yes.
Yeah, I have another quick thing that we're coming up against is we live in a college town, many of us do, and students who are going home or people that are leaving the state. So our state is having a lot of relaxed guidelines around being able to provide telehealth across state lines. So that's just another thing that CFHA might want to do some posting about.
Yeah, fantastic. As you see in the chat, there's also Caitlin notes that the other complexity is learning about providing televideo service across state lines, which is to your point. Yeah. So I'd like to take a moment as we reach the end of our time here to just ask you guys some basic questions just to take a quick temperature. So I'm going to put up a poll here for us. It should just take about 30 seconds to vote on or to look at. So just take a quick time, just work through them. Don't think too much about each of the questions. This is not the point of our session today, but it's just a way for us to kind of aggregate a little bit of information. While you're doing that, I want to wrap up our time by refocusing us on staff needs, because obviously we have, oh, no one's seeing the poll. Okay, sorry guys. I will figure out the polling. I'm not sure why the poll is not visible. Don't worry about it. Let's focus in on staff needs, because one of the key strains that I'm seeing nationally is a strain on our workforce. And so I wonder if someone in the chat could just quickly say something you're doing to support your teams or support your workforce. What are you coming up with that seems to be effective to help sustain the collective effort of our teams? And I do note that one of the folks who posted in the chat a similar question. You know, now that they're dispersed, Cindy Stone talked about 26 practices and 13 BHCs. And how are they supporting and connecting all this work? So I see here that one of the folks started wellness workshops, 15 minutes for the primary care teams via virtual delivery systems. Jody said a few hours of time for individual consultation to staff, residents, and physicians. Seen some of that. Katie's letting clinicians know that behavioral health is there as a resource. Open office hours, huddles available to BHCs in the region. Jesse, daily morning email with a quote and supportive uplifting, or self-care practice, a funny meme, etc. Yeah, I've heard of a lot of these sorts of efforts. Resource lists, of course, updated with self-care. Yep. Helpful practices via group me texts. Yeah. So these are all ideas. And I think one of the things we'd like to learn about is which of these work well in what kind of situations. So I know we're at the end here. I want to send us off in the right way. And I'd like to do that by sharing a poem that Tina Runyon shared with me. I'll read it for us as our closing meditation. And then if you all think this is helpful, we're happy to continue to provide this kind of space for you all to continue to brainstorm and troubleshoot and for us to share. This is the poem. I'll read it to us and end our time this way. It's titled appropriately, Pandemic. What if you thought of it as the Jews consider the Sabbath, as the most sacred of times? Cease from travel, cease from buying and selling, give up just for now on trying to make the world different than it is. Sing, pray, touch only those to whom you commit your life. Center down, and when your body has become still, reach out with your heart. Know that we are connected in ways that are terrifying and beautiful. You could hardly deny it now. Know that our lives are in one another's hands. Surely that has come clear. Do not reach out your hands. Reach out your heart. Reach out your words. Reach out all the tendrils of compassion that move invisibly where we cannot touch. Promise this world your love, for better or for worse, in sickness and in health, so long as we all shall live. Thank you all for your presence, your time, and your attention, and I look forward to hearing more from you all in the weeks to come.